Welcome, and thank you for joining us. During today's session, we will cover several topics, including understanding the cost by procedure and number of levels fused from quality, cost, and market performance perspectives, determining the methods and resources that can help you drill down to get to this level of detail, and discuss how the right data influences can positively impact decision-making and lead to sustainable change. Leading us through our discussion today, we have Kate Zentner, Senior Consulting Director of Intelligence for SG2, Joe Tomaro, Consulting Director for Vizient, and an interview with Dr. J, Professor and Vice Chair, Department of Neurosurgery at the University of Oklahoma College of Medicine. If you have any questions during today's session, feel free to submit them through the chat feature and we will address them at the end. Welcome, Kate and Joe.
Great. Thanks so much, Melanie. So we want to start out with a few trends and priorities to kick off our presentation on the radar for spine to really help us set the stage for why this idea of how to use data to drive change and demonstrate value is so important right now, whether you're coming from the perspective of maybe supply chain, or maybe you're a service line leader from an administrative or clinical perspective, or maybe something else, right? We know that spine continues to be a high priority area for really all of our members. It's commercial leaning. We see some nice margins and high growth, but it's competitive, and we're facing a lot of pressures here as well. Just to mention a couple of them, would start with growth as a priority here. So coming out of the last 2 years, we are starting to see a little bit of a shift. We've been focused more on staying nimble and kind of focusing on what's in front of us during the pandemic, but we are starting to see more members who are thinking through our plans for the next 3 years, 5 years, and how we're really going to kind of start to see that growth mindset again. But meanwhile, we're up against some new pressures and challenges. The first one I call out is rising complexity. This is happening for a couple of reasons. I think one of them is certainly the pandemic impact. Unfortunately, just to name one, we're seeing, of course, this skyrocketing incidence in behavioral health conditions. And we know that if we have patients who have behavioral health comorbidities who are in for something else, they tend to stay longer, they tend to cost more, and the management can be a little bit more challenging. So we're going to need to deal with that. Now, the other side of rising complexity is going to be more related to intentional changes. So that's more of a good thing as we see shifting sites of care. So just to give you an example, think of that lower complexity fusion case as you shift it to hospital outpatient, maybe even take it outside the four walls to an ambulatory surgery center. What does that mean, right? It means that the patients who remain across all of those settings is going to sort of elevate the complexity. Maybe we start to see a little bit of uptick in our length of stay in the inpatient setting and all of those things. So we'll talk about some of those shifts. And on top of all of this, right, you've got payment and policy pressures. We've got a burned out workforce we have to recognize that's probably not as stable as usual in terms of who's even on those teams. And the costs associated with business are going up. So all of this together is going to mean that we're probably going to need some real redesign and probably double down on processes to keep patients safe as well. So if we want to click to the next slide, I do want to pause for a moment on this concept of site of care shifts in spine surgery. Now, this has been a big topic for years now, and certainly probably no surprise to anyone on the line. But what we thought might be interesting to show is some recent data from the last couple of years that demonstrates that even lumbar fusion, which historically has sort of hung out in the inpatient setting a little bit longer, finally starting to see a status shift. So what you're looking at comes from Strata Decision Technology, which uses SG2's grouper methodology applied to a sample of hospitals across the United States. And what we're looking at is the proportion of lumbar fusion cases that are inpatient, which is orange, and hospital outpatient, which is the green line, and looking at that time period, between late 2019 all the way through the end of 2021. Now, important detail here, lumbar fusion does tend to be a little bit more Medicare leaning. And we had some codes that came off of the inpatient only list beginning in 2020. But you see here, as we kind of go across this timeline, it wasn't really until 2021 where we started to see that status shift begin to escalate, where the beginning of the year, you had kind of a 90-10 inpatient hospital outpatient split. By the end of that, we were looking more at 80-20 by the end of the year. So what's driving this? In addition to those payment and policy trends, we see, things like incorporation of enhanced recovery after surgery elements. So think pre-surgical optimization, multimodal pain approaches. Patient selection obviously is going to be huge in that, really sort of knitting together that episode to minimize length of stay, help patients recover, kind of get them in and out quicker and along to their recovery, as well as advances in anesthesia surgery techniques, lots of factors that are going to be impacting this. But flipping to the next slide, there are going to be some financial implications to this as well. So to sort of back up here, thinking about what happens when we flip from inpatient to hospital outpatient, realistically, we're still probably using a lot of the same stuff as we were before. It's the same ORs, a lot of the same things, but the reimbursement is going to change a little bit, might not be so similar, which highlights the need to really manage these shifts closely. And that's what you see on the left-hand side of the screen is an analysis to help you start to think through that from the health system perspective. So what you see here is based on national Medicare facility payment rates. Cervical fusion is now the example we're using. It's Medicare fee for service, so it's just one piece of that bigger pie, and really sort of meant to be directional, as we know that there are nuances here. But so starting all the way on the left, we see here that starting inpatient setting with that DRG 473, you can see already between that and the full hospital outpatient department rate, 1 over, that already we're looking at a pretty big change, about 25% less in terms of that payment difference from inpatient. Now, for those of you who are at teaching hospitals, academics, this doesn't even include IME or if you get dish payments and things like that. So you could, with that, there would be an even bigger delta that can be 8, 12 plus, percent added on. So you can see here it just sort of gets crunched a little bit more finally in the ambulatory surgery center, being even less than that. Now, right-hand side, a couple things to point out. From a policy perspective, one thing impacting the particular analysis that you see here, CMS prior authorization requirements. So midway through last year, CMS added to the list of procedures that require hospital prior authorization if you do them in the hospital outpatient department, cervical fusion with discectomy, as well as spinal cord stim. So basically what that means is it's sort of that additional administrative hurdle to kind of get those things approved and done. And the concern here is that that's causing delays. We've spoken with members over the last year, even seen a little bit of data that sort of starts to paint the picture that is what has played out to some extent. But in the long term, our suspicion is that this is more of a nudge towards the ambulatory surgery center for some of those cases that might have been lingering. And it'll be a subset, but the cases that were in the ambulatory or hospital outpatient department more out of convenience than anything else, it's not going to be the path of least convenience anymore. So it's those little kind of pushes more towards those sites. Now, lastly, on the pro fee side, you can see a data point here. It comes from a study that came out in 2020 where there was an analysis done looking at the inflation-adjusted change in reimbursement for the top 15 spine surgery CPTs that are used. Last decade, you can see that there's been a crunch there as well once you take inflation into account. So in summary, we're feeling some pressure. And on the next slide, what we want to show you is that we actually have more to go when it comes to these shifts. We're not hitting an equilibrium, here quite yet. This is still a very active shift. So let's take a quick look at the forecast left-hand side of the screen to see what we're projecting for the two procedures we just spoke about over the next 10 years. So I'll pause for a minute here, a little bit of background for those who haven't seen SG2's impact of change forecast before. This is an excerpt from that. It goes from the time period of 2022, projecting out to 2032. And what we're really doing with that is taking national data to begin with. We're projecting out what growth in demand will look like over the decade, both for inpatient admissions and across outpatient sites. If we looked not just at population growth, but if we sort of layer on top of that key impacts that are going to change what future demand looks like. So what you see here is the combined inpatient and outpatient forecast for cervical and lumbar fusion across that 5 years, as well as the next 10 years, and the split between inpatient and outpatient that we expect to see across those time periods. So for both, you can see that there are going to be some pushes and pulls. Overall, we are anticipating growth across both of these procedures, which you can see in blue. That's even as we see pressures to move towards more conservative care approaches, and as we have tech impacts that might, help us avoid some of that fusion, whether it's reducing repeats or things like motion preservation, for which the evidence is expanding. But with that, we have this counterbalance of epidemiologic factors. We have an aging population that's going to counterbalance some of that. So all in all, you see that we have growth. It's not going to be in the inpatient setting, though. You can see from that green to orange ratio of inpatient to outpatient. Cervical fusion, understandably, is a lot farther along in the shift. It's been going for 10 plus years at this point relative to lumbar. And the total opportunity for that to shift that you can see at the end of the decade is less. But if you look at that, compare it even for lumbar by 2032, relative to what we saw, before 2020, it's a big difference there. So programmatically, what does this all mean? We've talked about a number of pressures, and what we believe is that this means that programs who want to continue to be successful means that you're going to have to do a number of things. We've got to be operationally effective, probably more than ever. We have to be well coordinated, connecting the dots for patients, multidisciplinary, so surgical, non-surgical, all tied together. It's more than just the surgery now, right, as well. You're going to have to do all these things across sites. And finally, I'd highlight that you're going to have to be able to measure what we're doing, right? Both to your clinicians as you're looking at improving performance, and also, frankly, to tell your story to whoever your upstream channels are, whether it's a payer, an employer, a patient, or otherwise. So on a quick related note to that, I would just highlight from kind of a trends perspective, we are getting some questions at SG2 about centers of excellence as a way to sort of tell that story and build relationships with certain referral channels. There's no standard definition for what constitutes a COE. Could be a payer, it could be a third party, or really could be more of a marketing term, right? But ideally, the goal when we talk about COEs is to reduce variability, concentrate services sort of around a certain patient population to produce a better outcome. And oftentimes we're talking about reducing cost as well. So, but even understanding what that is, frankly, this is all a lot easier said than done. And that's what Joe's going to talk about. So before we dive into that, last slide here, I just want to give you kind of a quick snapshot to kind of get a sense, demonstrating that the breakdown of episode cost varies based on what we're talking about. So when you look at spine on the right-hand side, we tend to see that more of the cost is in that index admission by a long shot, followed by physician services. Whereas if we were talking about total joints, there's a lot more of that has a heavier post-acute element to it. And so that kind of gives us, when we're talking about spine, probably a good starting point for where to look at first. And we want to get a quick pulse on the audience. I'm going to flip it to Joe. So passing the ball to you to open up a poll.
Sounds good. Thanks, Kate. And again, thanks for the information. Obviously, with the growth in spine fusion procedures and the need to really focus on cost per case, we wanted to get a sense from the audience of, how does your organization share OR supply cost per case for spine fusion at a surgeon level? Are you doing it quarterly? Are you doing it twice a year? Once a year? D is as needed during a specific initiative, maybe spine RFP process, or E, have not shared this level of detail yet. So I'm going to leave this up just for a second, and then we'll move on to the next part of this as you respond back to that. Again, A, quarterly, B, twice a year, C, once a year, D, as needed, and then E, have not shared this level of detail. So when you look at the cost per case, I think there's a couple big things, because there's a lot out there that you could look at, and a few things I would encourage you to do as you begin this journey. Number one is that, without a doubt, the best barometer of true cost is going to come from supply chain. So being able to see what a vendor is invoicing for a specific product that's used in the OR is going to be the best. The issue with that supply cost is that generally a vendor will create an invoice per case. And again, if a surgeon's using certain spine implants from one vendor and then orthobiologics from another, or maybe multiple vendors, we don't have that opportunity to bring it together into one cost per case for the patient. So we're going to talk in just a moment about using OR data to be able to look at that. Secondly, I think that you have to look, if you take Kate's slide previously, you saw most of the cost was in the admission. And I would say most of that cost is in the OR, and most of the OR cost is going to be in the implant and orthobiologics. So sometimes this is a big data set to look at. So, maybe you want to just focus in on those areas first. And then also, I think the important part of this is you're going to need physician buy-in and input for there to be changes, especially as we look at utilization. So from a data perspective, really where you can get a good start is looking at OR supply cost. This slide is from a Vizient tool, Procedural Analytics. We've looked at this type of cost information I'm going to share with you outside of Procedural Analytics. But again, this is a good tool to at least get us started in a view of this. In this particular institution, you see that 360 lumbar spine fusion cases done. You can see that for the most part, that $20,000 of supply cost is above what we see as, a benchmark. So you can tell from this particular sample that the cost per case is high. And really what our goal then is to dig into why is that and what can we do about that? And there's really three different strategies that we can use as we're dealing with looking at cost per case. Obviously one is you've got to get the best pricing. So you'll hear Dr. J talking a little bit about us going through and doing some pricing on spine and orthobiologics, using some set pricing for pedicle screws or one-level cervical plates, interbody devices, or a certain cc of DBM, those types of things, to really get the best price as a starting point. You also can leverage maybe some market share commitments from vendors, depending on, again, physician preference, that you can get better pricing. We highly encourage that you work through those two parts of the process first before you then get to this utilization component of it. And I would say the utilization component is the area that I think really there's a lot that can be done in the future. If we look at the poll results, it looks like we're seeing people quarterly about 18%, twice a year, 3%, once a year, 6%, as needed during an initiative, 53%. I would expect that, and have not shared the level of detail yet, 19%. And again, so the utilization data, you can go anywhere from just looking at size utilization to certain types of orthobiologics. What I'm going to walk you through today is that how do you look at this on a per procedure, per level case, and the importance of this. In how I would summarize this, and even though I put in here the role of supply chain, but I would put on here, really, it's the role of supply chain service line leaders and the OR is to present, and here's the three key terms that I'm going to focus on. One is you want to focus on getting accurate data to the surgeons. That data has to be relevant, and it also has to be in a useful format so that the surgeons can make have meaningful discussions and also make effective decisions when it comes to utilization. And I'll show you some examples of how we've done this and worked with different groups with that. So first of all, when you look at this, I would look, and again, this is now a different data set. You can see 204 spine fusions done. These are all lumbar fusions. And you see that as we look at this, you can see there's 7 different surgeons performing these cases, a mix of orthopedic spine surgeons and neurosurgeons. And you see a total cost, if you go to the combination of that purple and gray bar, you see a total cost variation. Surgeon or provider number 3 has a cost of over $20,000, and provider number 1 has a cost of $15,000. And again, you see a lot of variation in here. And part of this is how do we look at this utilization? Now, if you look at that data, is it accurate? Yes, it's accurate. Is it relevant or useful? If you take one thing away from this web seminar today, especially if you're in supply chain or service line, do not ever present this data in this format right here to surgeons, okay? Because what you're going to begin is you're going to get more questions than response from the surgeons as doing something with this. Okay, so again, most important component of it, and what surgeons are going to want to ask to get to that relevant and useful area is they're going to say, okay, I need to know what procedures am I performing compared to what my cohorts are doing. Okay, I do as a surgeon, let's say I do multi-level fusions and the other people in the cohort only do 1 or 2 level fusions. How does that compare based upon the number of levels? And those are things that we can answer, and I'll walk through a methodology of how that looks. And then the third question that will be asked is how do long-term patient outcomes vary between surgeon? And that's a little trickier question. We're not going to address that today. That could be an entire another webinar, because a lot of times those outcomes really aren't reflected during the hospital stay. It's really a matter of taking and using a patient-related outcomes measure tool or looking at revision rate more long-term as part of that. Okay, so again, but we are going to address those first two, because these are questions as we're providing relevant and useful data to surgeons that we should be able to dig into. Now, I wish I could tell you that doing this was an easy automated process. It's not. We at Vizient are working on this right now. We're working on trying to make it a little bit more automated. I've had the opportunity in 3 or 4 different members to get a big data set extracted from the OR data in order to look at these procedures to classify them by lumbar spine procedures by procedure and then also by level. So let's start talking first of all by how do we determine it by procedure? Well, the biggest guidance of this, and again, if we're talking about mostly adult spine, you're seeing the interbody fusion device being used. So quite simply, by looking at this patient case and the number of items in that, you can look and say, well, there was one posterior lumbar interbody fusion cage used, so therefore it's most likely a posterior lumbar interbody fusion. And there was one of them used. So again, the rationale behind that is that there's a one-level fusion. Now, you can also look at leveling, if you will, by understanding the number of rods and set screws and pedicle screws. So in a one-level fusion, you would expect to see 2 rods, 4 set screws, and 4 pedicle screws. Okay, in a 2-level fusion, you'd expect to see 2 interbody devices. You'd expect to see 4 rods, 6 set screws, and 6 pedicle screws. Okay, now again, you know, what I found is that as I've looked at the data, you're able to classify between 80 and 90% of the cases fairly easily, that then you can get to a level of detail such as this. Okay, again, is the data accurate? Yes. Is it relevant? Yes, because now what we've been able to do is to break down and say, what's our total cost per case and what's our implant and orthobiologics cost per case, okay, for a 1-level, 2-level PLIF, a 1-level standalone, a 1-level and 2-level TLIF, and a 1-level and 2-level ALIF. So now we've got a better look at this because again, you know, most of this is really looking at just the, if you will, just looking at the overall DRG doesn't give you that granular detail that you need when you're looking at this type of information. Okay, so again, I highly encourage you to work through some classification scheme as you begin to share this information. Now, the last level of detail to make this really useful is to begin to share that information, you know, for a procedure at a surgeon level so that then surgeons can have some meaningful and useful discussions around that. As Melanie mentioned, we've had the opportunity to record an interview with Dr. Andrew J., who's a neurosurgeon at the University of Oklahoma. So we'd like to run that video because Dr. J will really give some insight as to what this means from a surgeon's perspective. So go ahead and run the interview, please. So hello, everybody again. I'm joined now for this part of the web seminar by Dr. Andrew J. Dr. J is a professor and vice chair for the Department of Neurosurgery at the University of Oklahoma College of Medicine. He's here today to give us the physician's perspective on really understanding the importance of looking at cost for care. So Dr. J, welcome. I appreciate you taking the time today.
Joe, thanks for the invitation. Happy to be here. Hopefully it can add some insight.
Yeah, I'm sure you can. So Dr. J, we spent the first part of this web seminar really making sure that as we looked at this information on costs, that we provided actual good data and relevant data to the surgeons. From your perspective, when you start looking at actual cost per case, especially in the OR, why is that important to you as a surgeon? What are some of the key takeaways of that information for you?
I'll be honest, I think many of my colleagues and surgeons maybe don't know the nuances of what value-based care is and so on and so forth. But I think my colleagues and I are all motivated by doing what's best for patients and also doing what's best for the organization that we work for, that we're a part of. So I think data transparency in the form of cost per case is extremely important to surgeons. We're all for the most part very much data driven. We're all competitive individuals. We all excelled in medical school to get to the station in life that we are now. So I think knowing having that data allows us to alter our behavior and incrementally improve on our performance each time. Even things as small as, if if we're displayed that information at the end of the surgery and we're compared to our peers, knowing if we're outliers or if we're doing extremely well, an order of magnitude above our peers, I think affects what we do in the operating room and the supplies that we use and how we can kind of be kind of best in our class.
Yeah, absolutely. And I think, Dr. J, one of the lessons that we've learned is that it's important to have a structure together in order to share this information. And a lot of the institutions I've worked with, we'll go through, let's say, a savings initiative on spine and orthobiologics. You bring the surgeons together, and then that just goes away. They stop meeting. What we've worked with you all at the University of Oklahoma is setting up a clinically integrated supply chain where we have these different core groups, and you see the one on neurosurgery and spine, that now is an ongoing group of people meeting. And you see the oversight committee and the steering committee. This then gives a forum for that information to be shared on a very consistent basis. Dr. J, as we share kind of the overview of what each of those core groups are responsible for, their purview, what have you found over the last 6 or 7 months? What's the makeup of the group? What's really worked well? What have maybe been some challenges and kind of some next directions for the group?
Yeah, great, Joe. So our group is structured. So I'm the committee chair for this group, well supported by you and other administrators at the University of Oklahoma. The voting core group consists of neurosurgeons and orthopedic surgeons, heavy focus on spine. And what we've said is when we start to discuss products outside of spine, we would bring on ad hoc members to provide that expertise and content as we discuss and vet those non-spine products. I would say that any group like this that's put together, I think, automatically evokes fears of trampling on physician autonomy or surgeon autonomy. And I think as we've started with these meetings for the past 6 months now, that's been a common theme. It's really this fear that a group like this is meant to tell people what to do or limit people's practices. And I think we spent a lot of time trying to convince our colleagues that that is not the purpose of this group. The purpose of this group is to provide information, to provide data, so that the group can make a decision. I think it's important, so me as a group leader, to really keep impartiality and kind of keep an even keel and not favor one specialty over another. Me being a neurosurgeon and being very careful not to give any preference to the neurosurgeons in the group. And I think we've done that. I think we've left plenty of time for discussion so that everyone's voice is heard and everyone feels like they have a say in the process, which is, I think, really, really important. I think this all falls apart when people feel like it doesn't matter whether they're there or not. It doesn't matter what they say because there's higher powers that may be that'll make the decision for the rest of the physicians.
Yeah. And Dr. J, as we look at this kind of the path that group is on, that core group, moving toward value-based care, a lot of the early, the blocks to the left were cost-driven. And again, I think it's important as we think about value-based care that we look not just the cost piece of it, but everything else as part of it. Do you want to talk about kind of the journey that group's laid out and where we're at now 6 months into it and kind of key next steps, if you will?
Yeah, absolutely, Joe. I think it'd be really elucidating. So we started off by looking at current state practice. And again, Joe and others in supply chain at University of Oklahoma really look to see if we make minimal changes, what that looks like. If we make major changes, what that looks like, and then let the surgeons decide. Once we know we had good pricing from our vendors, the next stage is really trying to look at what we use in the operating room and what outside of the standardized inventory that we came up with we're still using, and if there's an opportunity to kind of standardize that part as well. I think what my colleagues really would like to see now are clinical outcomes to make sure that as we move towards a more standardized inventory, that clinical outcomes are not compromised.
Yeah.
And again, I think that what might be lost now is what value-based care actually means, and I know that that's what we're getting to. That value is defined by outcomes over cost. So there's 3 different ways to increase value. It's to either you improve outcomes and keep costs the same, you keep quality the same or decrease cost, or you do both. You improve quality of care and decrease costs at the same time. And of course, I think our group would be interested in that third option, to have the best of all worlds.
So Dr. J, early in the presentation, we talked about getting this information in front of surgeons and really being cognizant of understanding cost per level and then cost per type of case. So, as I work with supply chain, this is the type of information we like to bring to the core group. And really, in this example, you see it's a 1-level posterior lumbar interbody fusion. So again, we now have 1 procedure, 1 level. This is 4 physicians. Again, this is not Oklahoma data. We're still working through that process at OU. But if you look at these 4 different physicians, you do see some very big differences in their total cost per case, their hardware cost per case, the implants. And part of that is driven by different levels or types of interbody devices. But some of the big variation is occurring in orthobiologics. So you see some physicians that are using DBM and cell-based, some that are using DBM and non-structural allograft, and it makes a big difference from a cost perspective. Dr. J, how would you share this type of information with physicians? What kind of conversation would that generate, and what would maybe be some next steps to try to get more consistency in utilization?
Joe, this is great. I think that physicians could be provided report cards after each of their cases compared to peers. So this is what your case cost compared to an average of your peers for the same procedure. I think it's really, you get into a lot of emotional conversations and probably non-productive conversations if you go to someone and say, you're spending too much, you need to not use this or not do this, because then it feeds into that whole idea that, well, this is all about limiting my practice and really infringing on my autonomy as a surgeon and as a physician. So data is non-emotional. So I think that physicians can be presented with this type of data, and they can make up their own minds. No surgeon, because of what we talked about before, the persona of a surgeon wants to be an outlier on the bad side. We all want to be outliers, on the positive side. That's what we're striving for. So I think that this data is just to provide information to our colleagues and allow them to make up their own mind on how to use it.
Yeah, and I think it's important to know that this is the disparity or difference in a 1-level posterior lumbar interbody fusion. I've seen data now that if you go to 2 levels, you're now even seeing more of a disparity between it. And then, you can even begin to compare the cost and variation between the procedure like a posterior lumbar interbody fusion with a one-level anterior standalone. So there's a lot of information. I think one of our main takeaways as part of this webinar is making sure that you have that information in a presentable format so that the surgeons can use that. Dr. J, it's been a pleasure, and we appreciate you spending time with us today. Just, any key last takeaways from our discussion here today?
Joe, thanks for allowing me to share this time with you. Not many, just one main point that, I view this as a quality improvement project. And one of the basic tenets of quality improvement is data transparency. And there's a quote that goes, if you're forced to stand naked in front of an audience, you might as well be buff. So I think that's exactly kind of what this is all about. When your data is out there, you want to look good. So then you're going to be self-motivated to make improvements yourself.
Yeah, really appreciate Dr. J's perspective on this. Before we bring back the slides back up, or as we bring the slides back up and talk through the last component of this, I think a couple comments of what he talked about. One, I want to make sure as we talk through this and we're talking about total cost per case, I also want to make sure that you recognize that most physicians don't understand what even the elements cost. So a pedicle screw or one level cervical plate or whatever the case is. So make sure, again, from a supply chain service line perspective, that you're sharing that. Secondly, I think the slide with the blocks showed the journey, and University of Oklahoma is on a journey right now. I do want to give a shout out to that group. That group's only been together 7 months. So for the group to be together 7 months, do a spine pricing initiative, orthobiologics, and now jumping into utilization, I think is a real testament to what they're doing as a group and their commitment to this. The last piece we wanted to talk about really was how does this influence understanding cost per case, influence new technology? We know in spine and lumbar fusion, there's all kind of new technologies that are coming through. This last few minutes is an excerpt from an article we did recently in TechWatch that I think will get posted in the chat here for everybody to see. But I think the important components of it is when we look at new products come in through this core group, we do look at the clinical, financial, and the market considerations for those. We don't look at it in isolation from a financial perspective. However, because we are talking about the financial aspects today, I'm going to target that piece a little bit. When you look at a new technology and the financial impact, it's important not just to say, well, and I'll use as an example throughout this, the 3D printed spacers now for lumbar interbodies, which are becoming very popular. And you can look at that and say, well, this device is $2,500 more than a like device that's not 3D printed. Well, I would encourage you to look at what are the clinical benefits of it. On the financial side, is there any impact in length of stay, OR time, those components? And is there even an impact on, use of other products? And I want to share with you an example that I think is very relevant. And this is an actual example. We had a surgeon in a facility, Surgeon B, that started using an interbody device that was $2,800 above, and this was a 3D printed spacer. It was $2,800 above what that institution was paying for the basic spacer. So again, the easy knee-jerk reaction is to go to the surgeon saying, these new spacers you're putting in are $2,800 more than the basic spacers, and try to have some dialogue. That's the wrong way to go about that. Instead, what was really relevant is that we were able to look, the surgeon, and it's really not just one, but surgeons that were using the basic spacer, they were using a lot of orthobiologics to the tune of $4,200 per case. The surgeon that was using the 3D spacer, his orthobiologics cost per case was $950. Okay, so again, even though the spacer was probably more expensive than it needed to be, and there was some negotiation there, and secondly, I don't see all surgeons decreasing their use of orthobiologics with these advanced spacers. Use those lessons of looking at the cost per case per level, as you think about these new technologies. One last point I'll make about new technology that I think is interesting, and this came from the article, is we did an analysis of 5 different hospitals that did a lot of lumbar fusions, and this was the procedural analytics data. you can see that hospital A, or the variation, you had one hospital using the 3D printed devices 60% of the time, and another hospital using it only 13%. I think it goes out to say, as a call out, that we really need to have these set methods of being able to look at these new technologies and address them. And the best way to start is to make sure that you know what the cost per case is now. So Kate, wrap up comments on market trends. What's a key takeaway from that part of this presentation?
Sure, absolutely, Joe. So beyond what's on the slide, I heard a few things here. So I'd say know your market and know your customer, right? Whether that's internal, external, it's for the purposes of quality and cost improvement, or for creating kind of those access channels to kind of be driving growth that we spoke about earlier. Today, we talked a lot about cost, outcomes, as Dr. J mentioned as well. And so this is really the data that you need to do the work. But once you've started to collect that, use it to paint a picture in other ways. So I'm thinking of things like payers and employers. They're going to certainly want to see this data. They also might want to see things like surgery avoidance, how quickly you're getting folks back to work. And so knowing that it is sort of challenging to measure things, I think knowing your audience, prioritizing what you want to measure, and sort of using those things to paint the right picture is going to be key, kind of regardless of where you sit in your organization.
Yeah, and my two takeaways, thanks, Kate. My two are, again, I'll say it again, don't ever put data in front of the surgeons without being the procedure and the number of levels. And then secondly, purposely, we spent a good bit of time with Dr. J talking about structure. We talked about data being accurate, relevant, and useful. I guess the fourth I would add is you want the data to be used. So again, if you from service line, supply chain, OR are putting all this data together and you don't have that physician audience to take it in front of it and make change, then there was a lot of work done behind the scenes for nothing. So we have some time left for question and answers. So we'd like to spend a little bit of our remaining time on that. So Melanie?
Yes, thank you so much to both of you for sharing your expertise with us today. And of course, Dr. J as well for sharing his time and insights. We did have a few questions that have come in. Joe, I'll start with you. One thing that came through during the chat is a concern around sharing cost per case due to categorization. What are some of the biggest or more common challenges you find when getting data accuracy to a level that can be shared with surgeons?
Yeah, I think the biggest part is what I talked about earlier in the presentation, is being able to look at that and identify. And again, there's some behind the scenes work to identify and look and say, okay, what interbodies are being used? So now I know the approach, and then also be able to look and say, how many pedicle screws and devices to know the number of levels. I would also say that if there's a way that you could put the OR procedure somehow and can get to that, so that it's not just saying it's a lumbar fusion, but it's a 2-level ALIF or PLIF, that's going to also help in providing that apples to apples comparison. But that is the most critical part of it, without a doubt.
Thank you.
And I'll jump in one last thing, sorry. One last thing I would say is that, again, with the level of data analysis, we typically are on a journey at University of Oklahoma to do a baseline, look at some change of the surgeons, look at data probably 6 months later. So again, this is difficult data to look at on a quarterly basis. So you want to think about what that timing should be.
Great, thank you. Another thing came through. We've got how well attended are the core group meetings, and are there any recommendations for non-university or private surgeons?
Yeah, so I will say the University of Oklahoma's core groups, we just had our call this morning at 6 a.m. Central Time. We have 9 surgeons as part of the group, 8 showed up, and that's been very consistent. And I do think, again, I'll give a shout out once more to the University of Oklahoma. They're providing good information to make surgeons want to get on the line and have these conversations. I will say that at that particular institution, you're dealing for the most part with university physicians. There is 2 private physicians that are part of that group. I do think you have to look at some different models. And you probably need to think about some physician engagement structures when you're dealing with private surgeons. That may be some co-management agreements, those types of things that need to be brought in as part of that.
Right. Okay. Kate, one for you. You spoke about the outpatient shift in spine surgery. Do your projections include ambulatory surgery centers, and to what extent are you seeing these cases migrate?
Sure. And the forecast that you saw have ambulatory surgery centers embedded in that outpatient. It's really everything that isn't inpatient, but we actually don't forecast that at the national level. The ASC shifts, particularly because it's so variable, right? So just to kind of give you an example, cervical fusion, 2019, less than 10%. It's like 6 or 7 maybe as a whole were done in an ambulatory surgery setting at the kind of national level that we saw. You have some states that are much higher than that. In fact, for the beginning of 2021, at least, I saw some states that were well above 20% in a commercial population who were done in the ASC. Now, where that's being done, it's states like Indiana and others where you see a lot of super groups, right? It's that physician entrepreneurship, independent group kind of element that really has pushed those things the most, although there will be other factors at the market level that lead to some of the variability that you see as well. So it's included in there, and we're seeing shift. It's you see cervical fusion probably going to a much greater extent than lumbar, but in pockets you'll see some of those lumbar cases in smaller numbers that are being shifted as well. If you get centers that have been a little bit more kind of bleeding edge about who they're shifting and how.
Yeah, thank you. That's going to be really interesting to keep an eye on all that.
Yeah.
Thank you guys so much again. As we conclude today, I just wanted to thank our speakers and the attendees for joining us. If you'd like some additional information regarding this topic, we've posted a link to the TechWatch page where there are some additional spine trend and the new technology adoption article available for you to read through. And the email addresses for Kate and Joe have been posted in the chat as well if you have further questions. And we will get back to those that we were unable to answer during our time today. But we really appreciate you and your expertise and for everyone joining us today. Thank you.
Thank you. Bye-bye.